The whole point, I think, is to empower the individual to take control over their own life. We don't want this disease to rule your life. It's always in the background if you have a chronic condition, but the main point is that you can still get on with living.
Welcome to Beyond the Count. I'm founder and CEO of ITP Australia and New Zealand and your host, Danielle Boyle. This is a space created for the ITP community by the ITP community, where we share real stories, expert insights and everything in between. Whether you're living with immune thrombocytopenia, supporting someone who is, or just curious about what life looks like beyond the bruises and the blood tests, you're in the right place. So whether you're driving, out for a walk, folding the laundry, or just sitting back and tuning in, let's dive in and go beyond the count. In this episode of Beyond the Count, I'm joined by Haematology nurse practitioner Rebecca Dring, who works across both the Royal Melbourne Hospital and Peter MacCallum Cancer Centre. Nurses are often the first and most frequent point of contact for patients with ITP, and Rebecca shares how her role goes far beyond platelet counts. From guidance, clinical expertise, to emotional reassurance and practical experience, she explains how haematology nurses help patients and families feel supported, empowered and truly cared for through their ITP journey. So today we're joined by Rebecca Dring, who is based at the Royal Melbourne and Peter Mac. Thank you so much for joining us today, Beck.
Thank you for having me, Danielle.
It's always an absolute pleasure to talk to you and to work with you and to even just hang out. So thank you for joining us on Beyond the Count. Today we're talking about the role of a haematology nurse when it comes to care in ITP. We all focus on the doctors, we all focus on the patients and the carers, but you guys are actually on the front line, you know, working with patients and seeing patients more often than not. So when you think about ITP care, you know, from your perspective, what's the role and what's the most important thing about your role?
I think one of my major roles is engagement into community care, but also to keep patients out of hospital. So whether that might mean if patients experience, say, a relapse in their ITP, they might notice, say, some petechiae or some bleeding or bruising. I always encourage them, go and get a blood test, let me know you've done it, and I'll chase those results. And then from there we can, do what we need to do. Or if it's over the weekend, just remember, and you're really worried if there's something that is quite an extensive bruise or you're covered completely in petechia, get your butt to the nearest emergency department because they will get a blood test result usually within a couple of hours, depending on where you're located. And I think they're the most important things. I'm there kind of as in the background, but the whole point, I think, is to empower the individual to take control over their own life. We don't want this disease to rule your life. It's always in the background if you have a chronic condition, but the main point is that you can still get on with living. And I think that's where my role is. And then say if you have a flare-up, my role might be, say, in medication management, whether it's tapering of, say, prednisolone or dexamethasone or something like that, just to keep an eye on the bloods. If you're starting a new medication that might need some follow-up, just to make sure that the dose is right for you. If you're experiencing any side effects, we'll do that. Or for the person who just might have a chronic ITP that's not on any maintenance, but has, say, a wisdom tooth extraction plan.
Yeah.
They might need, or any other surgery, and then they might need to attend for, say, some immunoglobulin just to help get you through that pre-surgery period, just to minimise the risk of bleeding. And I think that's where I am. I'm kind of like the stopgap between doctors, pathology units, and just a point of reference. And I think that's how I work. And as I always say to patients, you've got an email, you can always text me. More than happy to see what we can do. And go from there.
And it's about, reducing that anxiety, because I know that when you think your platelet count is really low, the one of the big questions that comes up in some of the closed groups and those sorts of things is, what should I do? So, well, what's your gut telling you to do? If your gut's telling you to go to hospital or get a blood draw, do it.
Yeah.
That's what it's there for.
And look, none of us like going into hospital. I'm the first to admit that I'd hate to go into hospital, but, it serves a purpose. And it might be that you need to be in hospital a couple of days. But I always say to patients, if you've got particularly tricky disease, if you keep that overnight bag packed, the backpack with a spare phone charger, some toiletries and a change of underwear and a toothbrush, you won't need to use it. But if you don't, you'll need to use it. It's kind
You'll definitely need it. It's Boyle's Law for sure.
It's about that. And, there are certain things too, if we can, people are always on our books, but we'll actually discharge you from our service, but I'm still always available. But we'll keep a close relationship with your GP or your primary care provider. And if there's any they need to contact us, we're always happy to be involved in anything as well. And we also have a lot of patients as well from regional areas. We now actually have like a virtual ED telehealth provider that we
Wow, that's amazing.
Patients through that. We're trialing it at the moment, but also it means that you can get access to a haematologist. So there's also haematologists on call for, say you've in a regional hospital, then at least then you can still get access to expertise, advice and stuff, and how somebody can help manage your potential flare.
So you touched there on the regional, you're looking after regional patients as well, because there are the haves and have-nots in ITP. So I live in a regional city, I live in Cairns. I don't have a haematology nurse, and even living in Brisbane didn't have that on-call component. And we do talk to a lot of patients and they say, if I've got that contact, I've got that one-stop number if something goes wrong, I can give them a call, I can send them a text message or send them a quick email. So I suppose one of the big things, I suppose maybe we need to clone you and have you all over the world and all over the country and into New Zealand as well to, help fill that gap because of the time difference from New Zealand to Western Australia. It's a really big gap. But would you mind us just cloning you so all ITP patients can have a Rebecca?
My husband wouldn't recommend that. He says that one of me is enough. So I don't.
My husband says the same about me as well.
But I think things are changing. I think areas are changing. It's getting hard now. Not everybody's going into medicine. There's always health professionals are getting stretched, particularly regional area feeling the pinch. And you see that with just GPs as well. It's really hard to get people to go to these areas. So I think a lot of these like satellite centres will start to pop up in terms of managing care safely as well. Yeah. I think if you have a haematologist and you're not necessarily got, say, a haematology nurse, I think it's really important to have a really good primary health physician. Now, not that could be somebody in the clinic, like a nurse or something that could be educated up and look, this is what low blood counts are, this is what this is. I mean, ITP is quite a rare condition, as we know, about 1,500 are diagnosed a year, but that doesn't mention all that we actually have on our books because you don't actually it's not a reportable illness, so there's no, say, national data or international.
Not yet. It's again on the list.
No. I mean, I've got a little local one, but nothing like what could be out there. And I've got over 300 people just on our books that have come through, but not everybody says an active condition. There are always, unfortunately, the individuals that don't respond to the typical treatment, so they might need more extra help. So I think engaging in that care, and if you get a blood test, ensuring that they can always chase those results for you. And if there's anything that needs to be acted on, then it can be acted on promptly, not in 72 hours, but hopefully within the 24 hours. And if those bloods can be turned around as quickly as possible between going through a lab and getting the result.
Yeah, no, I definitely agree. And I do find that, like, as I mentioned, patients with a haematology nurse or a direct contact have a much better quality of care compared to those that don't. And because, as you said, it's a rare disease, patients don't know what they don't know either. So it's a really steep learning curve, especially when you're first diagnosed. What is a platelet? Here's all these treatments, and you're sort of going, what? But I'm fine and healthy, or I'm actively bleeding and I'm now in the in hospital. And you're generally treated in hospital with the haematology oncology patients as well. So you're sort of going, but I'm not really as sick. So, all of these little nuances, so that you're just having someone like yourself to be able to go, climb people off the wall, help reduce that anxiety, be that sort of first point of call is really important.
And the help to manage those side effects potentially. And I think education for those type of things is really important, not just for the person with the condition, but also for their carers. You might also find that, some of the data that had came out through that Nevada study a few years ago, that fatigue is a big issue.
Massively.
That, emotionally you can be quite, challenged, whether it's you could be down or high, depending on if you're on steroids. And if you're not on steroids, you can still feel as flat as a tack or be incredibly emotional. I think it's ensuring that family members are aware that people can have those extreme responses. And, there's nothing wrong with that. It's just making sure that everybody's understanding of everybody as well. But
exactly. It wasn't actually me. It was because I was on this medication.
And I think that's something just to think of too. But in terms of like the fatigue that you can have all the time in ITP, it's also ruling out that might not be a contributing factor. So say you've got a woman who's still menstruating, they could have had really heavy periods and end up iron deficient because of the ITPs in the background. So it's really important that you always take everything else into account and that you also have regular testing for things as well, which is what we try and do as well. Whether or not that's something that gets done with your primary professional or with your haematologist, that's something that they can always be checked every few months or so.
Yeah. I think you're 100% right there. And that's, one of the important things that you guys do as well, is you are on the coalface. You mentioned how time poor everybody is. You guys are in the same boat. But, you are seeing patients before they get to the haematologist, and you can ask some of those questions before they actually get into the appointment, which can sort of probe and ask and dig a little bit deeper before the appointment, which I think is absolutely beautiful. So I'm going to ask you to share a story or an example of a time where you felt you went beyond the platelet count and you really supported a patient or whatever. Can you give us a bit of an example of that? You can only pick one. Like, I'm sure there's hundreds.
Too many. There are too many. But look, there's just little things. I've got a young lass and it was her 21st birthday. Well, of course, you had to look up to dress to the nines and, have a really good day. So she's worn these pair of high heel shoes with a blister on her heel. That blister caused her to drop her platelets because it got infected.
Oh,
and unfortunately, we all learned a lesson from that, because that one infection triggered a drop in the count. Because she's got chronic ITP, we now make sure that she's wearing comfortable shoes. She'll wear a set of flats, no high heels if she's going out partying. She's about 23 now. And it's little things like that. It's like forward planning. And I think they're just little things. And I don't know if that's necessarily beyond, but it's all part of a learning curve and educating mum, and then educating, don't mind if you have a drink, you can definitely go out drinking, but please have a glass of water. So I'll put on my mum hat and think, oh my goodness, I don't want to hear about any liver toxicity. Oh, shall I get a blood test? No, not if you've been drinking the day before. I don't know what.
No, don't.
But, it's little things like that. And I think the biggest thing that I can do as a nurse, as I said is to empower the person. Never be afraid if you've got something that you're concerned about to speak up. And they're like, oh, I'm worried about it being a silly question. Well, we all ask silly questions at times. But at the same time, I think if it gives you peace of mind, and I don't think there's any silly question around if you're concerned about something, particularly about your health. I think you need to ask that question. And if you can't ask it, say, from your health professional, because not everybody has, I've told people to change GPs before if they're not happy with the way the GP is. There is nothing wrong with seeking a second opinion. I'm not saying go to Dr. Google, but I think also the support agencies like ITP Australia, like what you offer patients, might be the only one with a similar question. You might actually find that there are other people that have those type of concerns. And I think, having like your online forums and having discussions, these are all things that you can actually, it kind of helps to normalise what people are going through and just say, oh, that's okay to feel like that. It's okay. No, that's not a silly question. Actually, that is something to be concerned about. I want to go overseas, but my platelets tend to bounce around. What do I do? Do I need to take an emergency supply of steroids? Or say the woman, I'm planning on having a pregnancy. How is my ITP going to be managed during my pregnancy? Do I need to come off certain medications? Can certain medications be taken in pregnancy?
Yeah.
how do I engage? And I think, ask those questions, whatever the question is. We've had, I think since the flare of COVID, there's been lots of conditions as well that are being triggered by people of all ages, people from 18 till the high 80s. So I think part of our issue at the moment is just making sure that everybody's safe. And it does get tricky. When we say about time poor, what worries me about being time poor, particularly around lots of the public holidays, is making sure that if people are a little bit more fragile than others, that they have the supports. And I've got supports in place that I can do things well.
Prepare.
Yeah.
Prepare.
Exactly. Don't go and get a blood test on a Friday afternoon because we won't get those results probably until a Monday. Well, that's not good enough. So it's also, thinking a little bit about what you're doing. You might be busy and that you can't get there on a Friday, but sometimes you have to put priorities as well. Is my health more important? I do have some petechiae. Do I need to do something about this now? Can we try and save off, a presentation to hospital on a Sunday morning, and then you get there and your platelet count's 1? So it's little things. It's about putting the onus back on the individual as well.
You're definitely right there. And I think that especially over the holiday season, so as part of the latest edition of The Count, we were talking about, how to prepare for the holiday season, but we are breaking it up by age group as well, because what you need to do for a toddler with ITP compared to, say, a teenager or a mature age patient, they're all vastly different. And it depends on where the disease is at, how do they feel, how long have they had the disease for, and, what are their triggers? Are they a bleeder? Are they not a bleeder? So on and so forth. So I think that everybody really needs to look at themselves individually, ask the questions, definitely. I'm one of those people that says there's no such thing as a stupid question, especially when it comes to your health, because you haven't had the education that, that yourselves or haematologists have. If somebody says to you macrophage or megakaryocyte, they're not part of everyday vernacular. And I didn't know about these words before my ITP diagnosis, and I can't expect other people to understand them either. So, and some of the names for different treatments and therapies, it's also really important to have that information and empower the people and empower the families collectively to be able to help navigate through all of that.
Thanks to our sponsor Sobi for their ongoing support of ITP Australia and New Zealand and our podcast Beyond the Count.
You've touched on this a little bit, nurses and yourself will normally help to reduce the anxiety and make people feel a bit more calmer, empower them and make them feel a little bit more confident. What are some of those, how do you approach some of the conversations when someone's feeling a little bit overwhelmed with their ITP or their bleeding or their treatments? How do you try and help navigate and start those conversations?
Firstly, it depends on the individual. I think that's a big, but also, like you said before, are they a bleeder or are they not a bleeder? And what is the normal for them?
Mm-hmm.
Because sometimes you could have had this low platelet count, but your platelets might never get back up into that normal range of 150 to 400, which is basically being done by collecting a group of Caucasian Europeans that they did a blood test and
is that right?
And they divided it by the number and they've got the lowest number and the highest number, and then that's how they've got a normal range.
Normal. So what's normal for you may be different.
Exactly. And I think what you actually have to be aware of as well is that what could be your new normal. So your platelets haven't gotten particularly high. But, if your platelets sit around, 20 to 50 and you're not bleeding, only time it's going to be a problem, like as I touched on earlier, is if you're going to have, say, planned surgeries. And then it might be that it's a risk of bleeding. So I think those are the things. And it's a re-education around that and making sure that people are really informed. Just before I got online, I had a person who's a newly diagnosed in their mid-70s. So there I was at ITP Australia printing out the prednisolone and the IVIG paperwork. And I put together a little package and I've sent them all the links via email, but I've also put it in the post. And I think that's one of the things. Yeah, if you've got that information, you know where to go to. But it's also about sharing it with your family. And I think when you inform other members, and everybody's like, oh, okay, that can actually help to alleviate some of the anxiety. Some people might be concerned, like say you touched on before, you get put on a haematology ward because you've got a low count, and all around you are all these bald people because they're having treatment for some cancers and things. I mean, that can cause anxiety in itself, from the young to the elderly. That's unfortunately where, because haematology does come under a non-malignant condition, or benign haematology, or classical haematology, whatever you'd like to call it. So that in itself can cause dramas. For a lot of people going to have a bone marrow biopsy, that test in itself, but don't you do that for people who have got leukemia or a lymphoma? Well, yes, we do, but we also are doing it. We want to have a look at what's happening with your megakaryocytes in the actual bone marrow. So megakaryocytes is another name for platelets. So that's the medical terminology for them. So it's important that we can actually look at things and explaining, well, we actually need to look at things on that factory floor. And by doing a bone marrow, that's where we can do it. And unfortunately, a diagnosis of ITP is a diagnosis of elimination. So, right, we can rule out, okay, so we can see that you're making lots of platelets, but why are they being destroyed? And it's more likely that it's just a peripheral destruction of those. Well, it's being done in the bloodstream because your body has identified it as being an antibody and is chewing them up. And for those patients that, have had their spleen removed and their counts are completely normal, and then all of a sudden their platelets drop again, do we have to have a little look to see if part of the spleen has grown back?
Yes, accessory spleens.
And we'll call that a splenoculus, which is a bit of a fancy word that, your spleen regenerated itself. It's a great word, splenoculus.
Yeah.
But, these are things that need to be done. So, if you've had a splenectomy and you haven't had any other dramas, and all of a sudden your platelets drop and you haven't done well, that's one of the first things that they should do. They should do a bit of a CT to make sure that you haven't had, or an ultrasound to make sure that your part of your spleen hasn't grown back, because I've had that in quite a few patients.
Well, see, I actually, when I was doing my research before my splenectomy, I was actually quite fascinated by that. I think the spleen is like the starfish of the human body, because with the starfish, if there's one leg sitting there, brand new starfish, hello. Whereas the spleen does the same thing.
Exactly. So, not everybody's regrows, and no. To be taking penicillin and have up-to-date vaccinations and things like that to make sure that you don't get unwell. But I think, that's one of the challenges that I love about ITP, because it's not just about the platelets. It's about the whole person. And I think where, you're not just, say, treating an appendix or something like that. You're treating an individual. And I think that's really, really important for anybody to feel like that they're not just a number.
Yeah, no. And like I said, we need to clone you. We just need to clone you. Happy to take donations to start that process now, everybody. Ultimately, I'd love to be able to have a call centre or some sort of online chat to talk to a knowledgeable haematology nurse. So if you are in a pickle and you don't have a network of somebody to talk to, you do have that option. So maybe one day, cross fingers and toes, in the sort of foreseeable future, we can probably get something like that and have some sort of roster system, etc. But until then, definitely talk to the people, because you don't know unless you ask as well. So you could be at your haematology appointment and not know that this service is available, and you could be chatting to a haematology nurse and they go, well, yeah, I do know a lot about ITP. Yes, I am happy to add you to the list and to add you to people that I follow up and talk to on a regular basis. Now, I didn't prepare you with this question, but I'm going to throw it at you anyway. If you were having a chat with registered nurses coming through the system and they were considering becoming a haematology nurse, and even better yet, a non-malignant haematology nurse, what would you tell them about what it's like being a haematology nurse?
I would say there's always something new to learn. I love learning. So, there's always new medications, new things, there's new treatments, there's new diseases that I just think, and I go, what on earth is that? So, but, again, you're always learning something, and I think, succession planning is a really big thing. So, for younger people, I do try and get them involved in projects, whether or not that's like, well, look, we've got all this data sitting in our database. We've got a few case studies. We've got some quirky little things. Can we present something at a local conference? I want you to do it. Happy to help, happy to be a guider, do those type of things, because that's how you get the new people interested.
Bring them over to the dark side.
Because a lot of people who do haematology, they want to look after the person with acute leukemia.
Yeah.
But it's not just that. There's a certain amount of people that are diagnosed with haematological cancers a year, but there are a hell of a lot of people out there who just need help to manage things like ITP. So there's certainly things and they keep you interested. And I love meeting people. I mean, I could have been that old telephonist in the 1950s answering people's phone calls because I like talking. So, so I think they're the things that I would do to get people interested. And it's just that education and sharing case stories and meeting people and doing those bits and pieces.
I think it's really important if you are considering ITP, come, the more the merrier. We love you all. We are a friendly bunch. We are a happy bunch. You will learn a lot and you'll be constantly learning. And
why on earth, if they've got no platelets, do they get a blood clot? Wow.
Right?
Teaching patients about, the signs and symptoms of those things. And, the patient says, gee, you've got a really sore calf. It's been sore for a couple of days. Is it red? Is it hot? Oh, just a little bit. Do you mind if we organise an ultrasound of your leg? Because then I deal with those.
Those DVT, yeah.
Oh, yeah, but I was okay when I went overseas. Oh, how long was the flight? Oh, 16 hours. Things, it's little things like that. And thinking, platelets can do very funny things. They are amazing little cells.
Yeah.
I think, being aware of how they work, what can happen, what could put people at risk, and trying to mitigate any of those risks as well.
Yeah.
And a lot of that is through education and, empowering. And if a patient is concerned that their primary health professional doesn't have a lot of information, I think refer them back to their haematologist and make sure as well that the haematologist is actually sending through your patient notes and records and blood and latest pathology results, that there is communication between them. Sometimes you might need to be the conduit of that. You might need to ask for a copy of any of the pathology results or even any of the doctor's notes if they're happy to share with you, and just so that you can ensure that your primary care physician has got this information. And usually a lot of GP practices have a nurse attached to them. So I'd actually become good friends with the local nurse too, because they're out there to help you. And if they can recognise you when you walk in and call you by your first name, and then, that way you'll always get what you want. Always acknowledge that person, you'll always get your own way.
Well, and the other thing too, and there is a chronic disease management care plan that you can actually ask for with your GP. So, and what that does is it's sort of like herding cats. You've got your haematologist over here, you've got this other specialist over here, and it brings everybody together. So everybody, the left hand is talking to the right hand, because a lot of the times we, see GPs prescribing something and it actually has a risk of lowering platelet counts, yet because the GP doesn't know about ITP, you don't have the left hand talking to the right hand. So consider investigating a chronic disease management health plan as well. But definitely making sure that you tell your doctor absolutely everything. Tell them where you're currently being seen, who your haematologist is, and making sure that when you get every blood test done, every test done, they get a copy is really important.
I think so, particularly if you've had a normal count 1 week and then all of a sudden it's dropped. What's changed? What's happened?
Yeah. And then that way too, if it means that then you get 2 calls or 3 calls, one from the haematology nurse, one from the haematologist, and another one from the GP, that's better than no calls at all, right?
Exactly. And I think that way at least you can say, oh, actually everybody's got me as the main player in this team.
Exactly. Exactly. And I think that's really important as well. So, and you touched on not having somebody that knows a lot about ITP, remembering it is a rare disease. GPs, if they do see an ITP case, they probably see 1 or 2 in their career, not often at all. And even some haematologists, they don't know a lot about ITP. They may be focused on malignancy. So consider, having them reach out to one of our medical advisors, connecting with them, or even if you're feeling you don't have the relationship there, feel free to, ask for a second opinion and have a look at the shared decision-making toolkit, because ultimately, when it comes to treatments, it is a shared decision. You're the one having to take these medications and live with this disease. Your voice is just as important. And there's lots of information on our website on those areas as well. So feel free to jump online, and a couple of other podcasts as well, actually. So, well, I think that's it. Thanks so much, Beck. It's been an absolute pleasure, as always. And you're an absolute delight. Like I said, I just want to clone you. Absolutely clone you.
But look, as I said, if anytime anybody has got questions, happy to, even if they wanted to drop me an email, happy to try and point them in the right direction. But I think always never forget, have a look at the ITP Australia website. It's in simple language.
Yeah, and always feel free to reach out to us as well. We're always, so as my husband says, he wishes I turned my phone off a little bit more often. I'm always texting, messaging, calling, talking to, emailing somebody else. So that's what we're there for as well, is to provide our patients with support, and our family, their family members as well. We've got some questions. So thank you so much. Really appreciate you jumping on the podcast with us. I hope to have you back definitely on another podcast or two, and we'll see you at the conference.
Bye.
I hope you all got a lot out of today's episode. Before we wrap up, here are 4 key takeaways from our conversation with Rebecca. Number 1, nurses are the bridge between patients and clinicians. Nurses provide continuity of care, translate medical jargon into plain language, and ensure patient voices are heard. Number 2, support goes beyond clinical monitoring. Rebecca highlights how nurses help with everyday challenges, whether it's managing side effects, preparing for surgery, or reducing anxiety during flare-ups. Number 3, empowerment is central to care. Nurses encourage patients to take control of their health, ask questions, and feel confident in managing their condition from day to day. Number 4, compassion and communication matter. Emotional support, reassurance, and advocacy are just as important as medical treatment when helping families navigate life with ITP. Thank you to Rebecca for joining us on Beyond the Count and sharing the vital role that nurses play in ITP care. We couldn't do it without you. If you're looking for support, connection, or information, visit itpanz.org.au. You'll find The Count, our quarterly magazine, patient stories, treatment information sheets, clinical guidelines, and a wide range of resources designed to help you and your family feel informed and supported. Most importantly, you'll know that you're not alone. There's a whole community here just waiting for you. If this episode was helpful, please share it with others in the ITP community and leave us a review on your podcast platform. It helps more people find Beyond the Count. We've got more expert conversations, patient stories, and more coming soon. So hit the follow or subscribe button to stay updated. Thanks for listening as we go beyond the count together.